Sir, we can start, sir.
Namaskar, everyone. I am Dr. Sumitra Jatti. I'll be the moderator for the session. And today's session is the 102nd DG Connect webinar session for INOC. And I welcome all the AUHT members, IAOH members, and the August audience. And along with that, I'd also like to welcome Dr. Manish Kumar Singhal. And Dr. Singhal is Senior Consultant in Medical Oncology in Indraprastha Apollo Hospital, New Delhi. And his topic for today is a flexible future, transforming the paradigm of HER2 positive breast cancer treatment. As we all know, being flexible is very important in today's scenario, as things which are flexible will tend to grow, whereas things which are rigid and blocked wither and die. And this applies to the medical protocols. The medical protocols change with time to keep the treatment protocols better for better outcomes. And I would like to introduce about the guest speaker. Dr. Singhal did his MBBS from St. GS Medical College, and he did his further studies from KM Hospital, Mumbai, and MD in internal medicine from PGIMS Rohtak. He got his formal training in medical oncology from Apex Institute, AIMS, New Delhi. During his tenure, he was selected for training at Oriel College, Oxford University, UK, and Barbara Ann Karmanos Cancer Center, Detroit, USA. His expertise spans in all types of chemotherapy, intensive protocols, immunotherapy, hormonal therapy, in addition to dealing with oncological emergencies, including medical care of patients. His ardent interest in academics and keeping up to date got him the Best Exam Award at ESMO, European Society of Medical Oncology, and he scored the top marks globally, making him the first and the only Indian to achieve this fame. He is also the member of Executive Committee of ISMPO, which is Indian Society of Medical and Pediatrics Oncology, a national body of senior accommodations of India. He is a joint secretary of NCR, National Capital Region Oncology Forum. He holds deep interest in breast cancer, lung cancer, gastrointestinal cancer, and lymphoma, leukemia, myeloma. Sir, it's a pleasure that you are here, and you will be telling us, giving a speech on the newer treatment protocols as far as HER2 positive breast cancer treatment is concerned. We are well aware that it has got poor outcomes and it comes with a higher mortality, and people like you who are on the mission to change this whole scenario. Sir, over to you.
Hi, thank you very much, Dr. Soumya. You will be very amazed to know that, if you look into the history of HER2 positive breast cancer, I'll tell you a brief story. So HER2 upregulation happens in about 20 to 25% of total breast cancers. That means out of 15 patients, you will have at least 3 patients who are positive for HER2, or maybe 4 patients. So that is the scenario of HER2 positive breast cancer. HER2 positivity gives aggressive behavior to the tumor, so they replicate fast. So ever since up till 2000, the median survival of metastatic HER2 positive breast cancer used to be about 12 months to 18 months. With chemotherapy was the only way, and they used to become very resistant to therapy very soon. In 94, they first manufactured the first targeted therapy of HER2 positive breast cancer. That was called as trastuzumab. 1996, they rolled out, and it was in Roche Genentech, who were the researchers. They put a lot of money into the research of HER2 positive breast cancer. 1996, they rolled out the first clinical trials of HER2 positive breast cancer, trastuzumab. Such was the initial success of trastuzumab. There used to be a lottery system to get onto the clinical trial. लोग क्लिनिकल ट्रायल से भाग जाते हैं कि यार हमारे ऊपर ट्रायल कर दी तुमने, तो लोग आना नहीं चाहते. लॉटरी डलती थी, मतलब अगर डॉक्टर के ऑफिस में 3 पेशेंट आ गए तो तीनों को ट्रायल में नहीं डाला जा सकता. वो लॉटरी डालेगा जी, देखो आपका नंबर लगेगा, एक का नंबर लगेगा. There used to be a lottery system to get onto the clinical trial. 1999, they finally published their results. They got the US FDA note in 1999, and 2000 it was commissioned for usage. Such was the success of trastuzumab in HER2-positive breast cancer that there was a movie, a Hollywood movie, which was premiered in 2006 called as The Living Proof. Ever since that, the saga of HER2-positive breast cancers have ever changed. Then they realized that the HER2 has a receptor which is bifid. So there are two receptors. And one of the receptor remains open. Therefore, the HER2 signaling is not completely blocked by trastuzumab. Then they made another drug called as pertuzumab. And then they combined trastuzumab and pertuzumab along with chemotherapy. The median survival increased from 4 years. So it used to be 1.5 years without trastuzumab, increased to 4 years with trastuzumab, and became 5 years plus with pertuzumab also. And now there is a new drug called as trastuzumab deruxtecan. What they have done is, along with the Herceptin, that is the HER2 antibody, we know that antibody of Y-shaped structures, they have added chemotherapy to it, to the antibody only. It is called as drug immunoconjugate. That means there is a chemotherapy attached to the antibody. So the chemotherapy gets delivered where the antibody goes and binds. The antibody will bind to the HER2 receptor, which is on the breast cancer cell. And there and then the chemotherapy will detach and enter into the cancer cell. The success of trastuzumab deruxtecan was such. I was in Chicago about last week, and in the presidential symposium, they published the results of trastuzumab deruxtecan, even in HER2 negative population. It was so unprecedented that the HER2 positive, even if it is 1+ positive, which we call HER2 negative breast cancer, even there the results were superb. There was a standing ovation in the presidential symposium of the American Society of Clinical Oncology 2022. So, science has really taken us a big way. Trastuzumab used to cost 1,45,000 in 2001. Right? Hardly anybody could afford it. उस समय के 1,45,000 कितने लोग afford कर सकते? It became out of patent in 2012. Then lot of lot of other companies came in, and now it costs just 15,000 rupees a month. And pertuzumab used to cost 5 lakh rupees for the first shot, then 2.5 lakh rupees of the other shot. Now again, it is going to go out of patent in 2024. So, and now there is a scheme, after 9 doses, you get lifelong free. So a lot of things have changed. It's very exciting. Of course, one of the problem remained that all these were injectable drugs. So you have to have a cannula. But now they formulated it as a subcutaneous injection. So this is exactly what we are going to discuss, so that you don't even need a hospital admission. You just buy the injection, and both trastuzumab and pertuzumab can be combined in one subcutaneous injection with similar efficacy. So can we go to the next slide? So I've already discussed that how these studies have changed the way the HER2 positive breast cancer, which used to have very poor outcome, now has increased to almost in excess of 5 years median overall survival, from 1.5 years to almost 5 years plus. Many people can argue that this is not still good enough a jump in median survival, but yes, I think the science progresses in a gradual manner, not at our wish how we want it to progress. Obviously it is difficult and very laborious to build up evidence, and a lot of patients have to participate in clinical trials, then only the science can progress. Unfortunately, the contribution from India in such participation has been very, very little. But we are only banking on the participation of Americans and European population, who mainly participate in these clinical trials in the name of scientific progress. Many females, lakhs of females across the world have participated in clinical trials, and they were not knowing that they participated on the inferior arm, and they went on to the inferior arm, but they still participated in the name of scientific progress. Right? So we have to be thankful to all those patients who have participated in clinical trials in the name of scientific progress, without even knowing that they are getting onto the inferior arm rather than the superior arm. Nonetheless, next slide. So this shows that how the chart of chemotherapy in HER2 positive advanced breast cancer or newly diagnosed breast cancer has changed. Now we have brought all these active agents even in very early stage tumors. Those who are more than 2 centimeter, we usually treat them with pertuzumab and trastuzumab with chemotherapy. About 70 to 80% patients can achieve a pathological complete remission. That is when you do surgery, you don't find any tumor over there. Such patients have unprecedented survival. More than 90% patients will get cured of their illness. Those who do not achieve, then they go into a drug immunoconjugate, that is a trastuzumab with chemotherapy attached to it. And even this has become generic. Zydus company in India has brought the generic of TDM1. It has become much cheaper now. So, and of course, those who have less advanced disease, they'll get lesser drug. Next slide. Next slide. So I've already discussed about that IV access has been a problem because usually breast cancer patient will have surgery done on one side and then they cannot use the same arm, whereas the other arm can be used. So, but getting repeated cannulas every 3 weeks is not an easy thing and the veins get exhausted. So we were looking at a subcutaneous formulation. Next slide. So, but when you give trastuzumab or pertuzumab, it's not like giving insulin. When you give insulin, you hardly inject 0.7 ml or 0.5 ml. Over here, you have to inject 10 ml to 15 ml. So to inject 15 ml into the subcutaneous plane, you need to have so much accommodation in the subcutaneous plane. To make it accommodative, you add hyaluronidase. Hyaluronidase with the injection causes disruption of the normal fibrous tissue for a short while. It has got a very short half-life, and you can give larger volumes in the subcutaneous. Gradually, this hyaluronidase gets absorbed, and then the plane becomes absolutely normal. It is not like a big bulge, because if you give 15 ml in subcutaneous, it becomes a big bulge. So there's no big bulge. Hyaluronidase keeps on dissolving the fibrous tissue, so it disseminates in a wider plane and gets absorbed gradually over a period of time. Next slide. So this is a pictorial presentation of how a subcutaneous injection with hyaluronidase you can easily give large volumes. And you can see that the fibrous tissue is degraded and hyaluronidase helps dispersion of the subcutaneous formulation into a wider area where there's no major bulge or no major pain while giving such a large volume of fluid in the subcutaneous plane. Next slide. So this is without hyaluronidase, how a bulge will be there, but with hyaluronidase, there's hardly any bulge. Some thickening of the skin would be there, but there's no bulge. Next slide. Next slide. But now the proof of the pudding is in eating. Now you have to have proof that whether you are achieving the same aim or the same level of drug in the blood by giving it in the subcutaneous plane. Next slide. So next slide. So the phase 1 study was done, which checked the blood levels of the drug of pertuzumab and trastuzumab when given in the subcutaneous. Next slide. So this was PK-PD studies. Next slide. And so they showed that it is feasible to give. Then they did a larger phase 3 trial, which is called as the Federica study, where almost 500 patients participated. 250 went on to the IV arm and 250 went on to the subcutaneous arm. And the primary endpoint of was the C trough level, that is the plasma trough level of the drug, which is reached by giving it in the subcutaneous plane. Next slide. So you see that the trough levels was actually slightly better with the subcutaneous formulation as compared to the IV formulation. The max, of course, the max is reached faster with the IV form than in the subcutaneous form, but that does not really matter. What matters is how much drug is remaining in the blood still at the time of just before the next dose is due. And that C trough level was better with the subcutaneous formulation. Next slide. How does it work on the patient? So the C trough level was actually better off with the subcutaneous. Next slide. Now the next outcome is the response, the tumor response. The tumor response, as you see, the red and the green, they're absolutely same, 59.5% versus 59.7%, which is absolutely similar. So there was no change in the efficacy on the tumor by giving it in the subcutaneous fashion. And this is on 500 odd patients randomized to 250 to this arm and 250 to that arm. That is how you do studies in randomized controlled clinical trials. Next slide. So toxicities, absolutely similar, no change in toxicity. Next slide. So diarrhea, everything was absolutely similar with no difference between the two treatment arms. Next slide. So as you can see that subcutaneous or IV, there is no statistically significant difference between the two arms. Next slide. As far as we know that trastuzumab and pertuzumab very rarely, in about 2 to 3% patients can cause cardiac dysfunction. So you have to monitor cardiac dysfunctions. As a matter of fact, the cardiac dysfunction was slightly better with the subcutaneous formulation as compared to the IV formulation. So you may be safer as far as cardiac functions are concerned, although it is hardly any, 2% is nothing, but it is slightly safer. Next slide. So it achieves good aim, it is much more patient friendly, and it is safety is also similar. Next slide. Now we have to see whether how does the patient interpret. This is what we interpret as scientists or as doctors, but let's ask from the patient how the patient interprets subcutaneous is better or IV is better. Next slide. So they did a study on this also. This is called as the Frenska study. So they asked the patient by a questionnaire, what did you prefer? Next slide. So the preference was 88%, 83, 85% in all patients, they preferred the subcutaneous formulation. However, 15% patients did prefer the IV formulation. So the main reason of subcutaneous preference was less time in the clinic, more comfortable administration, no need of an IV chemical. Next slide. So this is how the patients are satisfied or not satisfied with it. So 88% were satisfied with the subcutaneous formulation. Next slide. So how do you do it? Usual time for an IV formulation takes about 60 minutes each for pertuzumab and trastuzumab. So it is about 120 to 300 minutes. And whereas the subcutaneous formulation takes about 8 minutes for the loading dose and 5 minutes for the every subsequent dose. Next slide. As far as skin injury or skin reaction is concerned, there's hardly any. I've already used it in quite a few patients. There's hardly any subcutaneous injury or pain or anything. It's very, very smooth. But there's hardly any problem. Next slide. So this is just a summary of what I've already said, that most patients are very satisfied and the efficacy is similar. There's no change in efficacy. The safety is also similar. As far as other impacts are concerned, it is much more same, whereas the IV cannulation is not required and the subcutaneous formulation is easier. The cost is same between what is Perjeta or IV versus oral. IV versus subcutaneous. The cost is also similar. Next slide. Next slide. So this is given in the thigh. Usually what you do is you give in the upper 1/3, then use the other thigh, the upper 1/3, then the middle 1/3 of the same thigh, then middle 1/3 of the other thigh, then lower 1/3, the lower 1/3, and then again back to upper 1/3 of the right side. So you can keep changing the thighs. It's a lateral part of the thigh which has to be injected, and it is a gradual injection. Since total volume is 15 ml, you take 2 ml per minute injection rate and gradually keep injecting, and you have to finish the first loading dose in 8 minutes because it is 15 ml, and the subsequent dose is 10 ml, so it takes 2 ml per minute, that means 5 minutes. Next slide. So this is exactly what is given. Loading dose is 8 minutes and maintenance dose is 5 minutes, and after that you just observe there is no reaction or anything, but usually there is none. Next slide. Next slide. Of course, you have to take consideration of the patient privacy. So you have to put the curtains around because you have to expose the thigh area. And of course, there has to be a nurse who is assisting you. Next slide. So provides benefit in cost, time, and reduction, because if you're not occupying an hospital bed, then also the cost goes down. Unless somebody is reimbursable, then they might like to do the bed thing because they have to take a reimbursement from an insurance company. But you can do it in the OPD also, very, very safely. So it definitely reduces cost, time, and reduction on the patient, as well as the healthcare practitioners. The overall burden is reduced. It is less invasive. There's a fixed dose formulation because there is no dose calculation as per the body weight. It's a fixed dose formula for everybody. And there's no dosing errors which can happen, or dosing error at the time of dose calculation or weight management, or whenever you have to take a weight, the weighing machine may show some different weight at all the times. इस वाली machine में ये आता है, उस वाली machine में ये आता है. So there is no dosing error which is there. Is fixed dose formula, and so that way it is very easy. You don't have to remember the weight. You don't have to do any calculation. Fixed dose formula, easy to give, reduces time, and there's no new safety concern. Next slide. So this is just to summarize, the formulation has been accepted by the Drug Controller General of India. It's approved by the US FDA, similar efficacy and a simple subcutaneous injection. So likewise, the cancer treatment has not only become more efficacious, but much more patient friendly and much less toxic. With that, I think I'll end, and I'm happy to take any questions.
Any questions from the audience? It seems there are no questions as of now. Thank you very much, Dr. Manish. It was quite insightful. The very key points. The first point was you told us about the prevalence of the disease. The 3 out of 15 are HER2 positive patients in breast cancer. You told us about the survival rate with the new treatment modalities. Previously, it was 12 to 18 months. Now it's 5+ years. That's a great thing, actually.
And I'm talking of advanced stage cancers.
Okay, fine.
If you are talking of early stage cancer, then it is highly curable.
Highly curable, fine. And you told us about the decreasing cost. Previously, it used to cost a lot of rupees. Now, the cost coming down to 15,000 rupees per month. That's a great achievement as far as I'm concerned. And the present combination with the subcutaneous therapy, which is very much acceptable to the patients. It is less painful. You showed the data that it is more preferable, and it gives more satisfaction also. The data shows. So that was a great study, and we came to know about the modalities, the present modalities. I have one question for you, doctor. That is it available at all the centers in India? Is it widely?
Yeah, it is available now. Yeah, very much. They've already launched the drug. It is very much available, and we are using it in many of our patients already.
In mainly urban centers, or is it?
See, there are patients who are very obese. They don't have a cannula. They don't have veins. We are not even bothered. Cannula ki zarurat hi nahi. Why to put a chemo port? That saves the cost of a chemo port. अब तो subcutaneous injection लग जाता है.
Right. And that was great.
जो obese होते हैं उनमें तो fatty fat होता है. कोई problem ही नहीं है. It's very easy to give an injection.
Right. No, I was asking whether the treatment is available in only urban centers or in semi-urban areas also.
It is available anywhere. You just have to buy the drug, and the doctor has to be trained to give the injection. That's it.
And moreover, it is more safer as far as cardiac.
Slightly more safer, although we cannot say that dogmatically, but it is slightly safer. This is what is appears from, because the percentage is 2%, 3% over there, and 2% over there. So it's only a minor difference, but a consistent minor difference. So perhaps it is safer because you don't reach the Cmax. Perhaps the Cmax that you reach with IV perhaps causes more cardiac disruption as compared to not reaching a Cmax, but yet remaining in the blood for the cancer cells. So I think that may be one of the reasons which I can think, but not really.
Thank you very much, Dr. Manish. I mean, these things prove that people like you exist. So people like you ensure that cancer is only going to be a chapter in the life. It is not going to be the whole story. So thank you very much for taking on that mission. People like you are smart, fast, flexible people on this mission. They really make a difference. Thank you very much. Over to you, Shivang. Shivang, are you there?
Yes, sir. Yes, sir. Yes.
Right.
Yeah. Thank you very much, sir.
Right. Thank you, Shivang. Thank you, Tarun, and thank you to Dr. Soumya also.
Yeah. Thank you, sir. Thank you very much. Thank you for your time, sir. Thank you very much.
Namaskar to all. Namaskar.